Good morning, everybody. My name is Will Sayde. I'm a sports medicine trained orthopedic surgeon out of the Orthopedic Institute in New Jersey. I've been charged to talk about rotator cuff and biceps tendon problems. Obviously, we've talked a lot about cuffs already this morning, so I'm going to try to fly through some of that and pick up some of our time because obviously we're running a little behind and want to get to our breakout session to do some hands-on stuff. A little bit about our practice. We're all over Warren, Sussex, and Morris counties. Our closest office here is in Cedar Knolls. That's where I spend a lot of my time. Objectives today, talk a little bit about the anatomy and physical exam of the shoulder and how that can help pinpoint some of these common diagnoses and treatments. Talk a little bit about how clinical correlation with advanced imaging helps, and to talk a little bit about the surgical indications involving specifically the rotator cuff, the bicep tendon, and its insertion on the top of the labrum. So we've already gone over the anatomy. We're not going to belabor this, but a lot of the issues we're going to talk about with regards to the rotator cuff or with the tendinous insertions of these very important muscles in specific areas on the proximal humerus bone. A little bit about the labrum. So we've talked, Casey just talked a little bit about the labrum and its role in instability, but as a pain generator, a common pattern that we see is with superior labral tear. So kind of the 12 o'clock position on the face of the glenoid up here, if you think of this as a clock. And this is a very important region, mainly because of the insertion of the bicep tendon, which we'll be talking about in a little bit. These are tears that were described a lot in overhead athletes, but we see them a lot degeneratively as well with concomitant rotator cuff pathology. It's a source of pain for a lot of patients. So we tend to see it a lot on MRI reports. You might see MRI reports that are looking for rotator cuff issues, and you'll see the mention of superior labral degeneration or tearing, or SLAP tear is the acronym, superlabrum anterior to posterior. There's lots of different subsets of it, which are more academic in nature, but we do see them a lot arthroscopically and address a lot of them as concomitant pathology with rotator cuff issues as well. Subjectively, the painful shoulder that has rotator cuff problems has pain, particularly with sleep. As was mentioned before, sleep disturbance is one of the most common things that bring shoulder patients into our office as orthopedists, and probably similarly in the primary care community as well. Pain with lifting, sometimes fatigue with repetitive lifting, especially in our manual laborers. That can be both from an inflammatory overuse, bursitis and tendonitis, or with a rotator cuff issue as well intrinsically. Some patients do get mechanical symptoms, stiffness, and subjective weakness with lifting as well. Obviously, there's lots of parts of the shoulder, as you've learned this morning, that can be pain generators. We're going to be focusing a little bit right now on the rotator cuff itself and the long head of the biceps at its insertion at the top of the labrum. We've also hit a bunch on some of the physical exam findings. We'll go over some of those specific tests in the breakout session to help pinpoint some labral testing versus cuff and bicep testing. Specific to rotator cuffs, especially for the older folks, just looking at their back is very helpful as a first screening test for someone that has chronic shoulder pain. As you start examining more and more shoulders, you'll note that the 75-year-old gentleman who's had 10 years of shoulder pain sometimes has significant atrophy from a chronic rotator cuff tear, where you can visibly see the loss of muscle mass above and below the scapular spine. Obviously, you can look at the AC joint. You can look at the way that their scapula moves if they're having more chronic issues mechanically. We'll talk a little bit about the Popeye deformity when we talk about biceps issues. Strength testing is definitely one of the most important keys that was mentioned earlier. If you're looking for a test to see if a patient has a significant chance of having a full-thickness rotator cuff tear, might need to see an orthopedist. Just doing simple manual muscle testing, if their internal rotation, external rotation, and checking their supraspinatus elevation, which we can show you in the breakout session, is probably a great test for trying to figure out if a patient might need advanced imaging. And then we can talk a little more specifically about the provocative tests in our breakout session as well. These are a couple of them that we'll show again in the breakout sessions, both impingement testing, some biceps testing, and then labrum and cuff testing as well. And we'll give you a few of these that you can take home with you that gives you the best yield, although, as it was mentioned earlier, there's no perfect test for every specific diagnosis in the shoulder. It's a combination of the history and the exam. Rotator cuff problems really do live on a spectrum, ranging from the tendonitis, bursitis, overuse, inflammation, to partial thickness cuff tears, sometimes with symptoms and sometimes without, and then full thickness rotator cuff tears, which again can also be asymptomatic. There's various ways to grade these, both in terms of imaging and arthroscopically, in terms of their acuity, their size, how much weakness the patients have on exam. And then there's some special cases like impingement in an overhead athlete, which is a special case, and calcific tendinitis as well. MRI certainly is very helpful in trying to delineate some of the specifics of severity of rotator cuff testing. The picture on the left shows what we talked about earlier as that fluid gap where the tendon is retracted and fluid in the subacromial bursa fills in that space, and that's a sign of a retracted full-thickness cuff tear. And then as Eric had mentioned, there's a special type of chronic rotator cuff tear arthropathy that you get that is very distinguishable from glenohumeral arthritis and is also treated differently as well. Initial treatment of most cuff pathology is done with conservative treatment. The exceptions are really the acute traumatic tears in young folks, but in general, anti-inflammatories, activity modification, physical therapy to help try to rehabilitate all of the supporting muscles of the scapula and the rotator cuff, and subacromial cortisone injections are pretty standard of care for a lot of rotator cuff issues. There are certain criteria that we use in general. The rotator cuff problems can be very unique person to person in terms of how they affect the person, how they affect their work, their play, their life, their daily activities. But failure to progress or tolerate with physical therapy for a certain amount of time for partial thickness tears, acute full thickness tears, certainly we were pretty aggressive on if they're having significant disability, and persistence of symptoms in a patient that has good range of motion, has failed physical therapy, having a lot of symptoms that affect their sleep or their activities of daily living are patients that we do frequently operate on. Rotator cuff surgery nowadays is mainly done arthroscopically through a combination of techniques. We can put the camera in there, take a look, mobilize the tendon, and repair it like we had done previously with open surgery. Same techniques of trying to incorporate ways to improve soft tissue healing to bone, and a lot of it's based on the specific tear pattern, patient's age, and a lot of the outcomes are probably directly related more to the quality of the tendon tissue and the patient's age and some of the intrinsic factors like blood supply to the rotator cuff versus the exact technique that's used between single and double row and some of the things that we discuss at orthopedic meetings. In general, although there's various techniques, we're trying to take a soft tissue structure and repair it back to bone. So we decorticate that bone, we try to promote healing, and then we use a variety of techniques to try to provide a compressive force of that repaired tendon to the greater tuberosity bone so that that body can heal. Obviously, the healing of the patient from an intrinsic standpoint is going to be the most important factor in whether they're going to heal or not. That's why smokers don't do as well. But in general, there's a variety of techniques. The picture on the bottom, this is a pretty standard double row repair of the rotator cuff. So these are very thick Kevlar lace tapes that are attached through suture anchors. This one has 4 anchors, and we're just trying to get that tendon to stay affixed and compressed to the bone so the body can then heal it. Recovery from rotator cuffs, every surgeon has their own protocol, but in general, you start with range of motion. I sling them for 6 weeks. We progress them to strengthening. Most people get back to most heavy lifting by 4 to 6 months, but functionally, patients can make improvements out to at least 12 months as the patient continues to build up their endurance with particularly their overhead activities. Superior labral tears and partial tears of the bicep, very common things that you'll see on MRI reports that can be pain generators concomitant with rotator cuff issues. The categories that we see most commonly in terms of superior labral tears, you can have an acute labral tear, you can have a degenerative labral tear in older patients, you can have full or partial tears of the bicep tendon. The obvious, most common one that you might see in the office is the older gentleman who feels a pop in their shoulder and then has a Popeye deformity where their bicep muscle drops down. That's someone that probably had some significant partial tearing of the long head of their biceps in the front of their shoulder for quite some time, and with some injury or with time, that partial tear ruptured completely. A lot of times these are treated non-surgically if they have an isolated proximal bicep tear. Other than the deformity, a lot of times the pain and subjective symptoms will improve with time and physical therapy. However, if a patient has an acute pop and has a Popeye deformity, there is a high rate of concomitant rotator cuff pathology. So a lot of times if a patient comes to my office with what seems like it could be just an isolated proximal bicep tendon tear, but they have weakness in their cuff testing as well, I usually do get an MRI because a lot of times they do have rotator cuff issues, sometimes requiring surgery. Partial thickness tears of the bicep tendon in isolation are usually treated conservatively to begin with. Occasionally, we do go on to do arthroscopic surgery to address the bicep if that pain just does not improve with conservative treatment. In young athletes who have supralabral tears, sometimes we will fix it like we fix labral tears in the dislocating athlete. So this is a picture of a patient that had a tear of their superior labrum with a repair that also extended down the front of their labrum. So there are techniques to repair the glenoid labrum back to the socket, just like you would do in an unstable patient in young folks. The issue with doing that in older folks that have degenerative supralabral tears can cause excessive tightness, and a lot of times addressing the bicep tendon has a more predictable outcome. So when we talk about bicep tendon tears or partial tears that are painful, there are two main ways that we address that arthroscopically. In the 80-year-old patient who is just having pain, sometimes we literally just cut the biceps and perform a tenotomy. So we take this degenerative tendon here and we literally snip it at its insertion to the top of the glenoid, and that will retract down the arm and give them the Popeye deformity. But with time and physical therapy, their pain from that constant tugging on that partial tear can improve. In some of the younger folks, manual laborers, where we want them to have their best chance at good function of their bicep without the cosmetic deformity, there are a variety of techniques to cut and then reattach the biceps. That's called a tenodesis procedure. Some of these are done arthroscopically. Some of these are done open. The way I do it is with one of these little unicortical buttons here through a separate incision from my arthroscopic evaluation. And again, we do this a lot when we see this pathology when we're in someone's shoulder dealing with the rotator cuff at the same time. And that's a quick overview of cuff and bicep tendon. Thank you. Any questions on stuff we didn't talk about so far? Yeah. So, in a lot of these rotator cuff patients, ranging from the bursitis patients to the inflamed partial thickness cuff tears to the small full thickness rotator cuff tears, our initial treatment is pretty similar. It's all about trying to reduce inflammation, promote good flexibility and mechanics of the shoulder, and strengthen the supporting muscles of the shoulder and the rotator cuff. So, a good anti-inflammatory regimen, modifying their activities, a physical therapy program with a home exercise program, and then supplementing that with a subacromial cortisone injection is pretty standard for a lot of these patients, and a lot of them do get good relief from that. The therapy component for especially chronic rotator cuff tears cannot be understated. There's a lot of literature that's come out in the last few years about trying to figure out which patients have a symptomatic full-thickness rotator cuff tear that are going to go on to surgery and who will not. When I was doing some of my board research questions a few months ago, there was an article that we reviewed, I think from JSES, talking about what are the predictors of patients who fail conservative treatment for a chronic full-thickness cuff tear. And they looked at size of tear, age of patient, as many demographics as they could find. And a certain percentage of the population that they followed obviously went on to surgery because they failed conservative treatment. But the only factor that they found that was actually significant clinically in the evidence was what the patient's subjective thoughts about whether therapy would work or not is. So we know that therapy can help a lot of patients with reducing their inflammation and promoting good mechanics, and that is definitely a very important part. And I try to tell patients, not every rotator cuff tear hurts the same, and if we can try to get your shoulder muscles balanced, there is a chance that your pain will get better, and we don't operate on every rotator cuff tear. So a combination of anti-inflammatories, cortisone injection, physical therapy with a home exercise program is certainly reasonable conservative treatment for the vast majority of rotator cuff issues and injuries, partial tears, full tears, just bursitis in young folks. And we talk about how there's a very good chance that that is going to help you, and if it doesn't, then we talk about surgery for some of the full thickness tears. Yes? That's a good question because there's a lot of stuff in the lay press about regenerative medicine options for a variety of orthopedic issues. So in general, the best evidence, and this is obviously a lecture into itself, best evidence for PRP injections, stem cell injections in general is for chronic tendinopathy. So if you're looking for best evidence that something is going to be helpful, chronic tendon issues, Achilles tendinopathy, chronic lateral epicondylitis, tennis elbow, has very good results relative to cortisone in a lot of, some of the well-done studies, which is not a huge wealth of really well-designed studies for it. For early osteoarthritis, there's some evidence it could help. For rotator cuff issues, there's no great evidence that proves that it can promote healing to avoid a surgery. So there are certainly practitioners in the community that are injecting PRP and stem cells, different preparations of what is really, 30 different types of products to try to help the body heal. There's no great evidence that shows that it can make a rotator cuff heal completely. Some surgeons do use it as a supplementation to procedures to try to augment healing by adding a biological supplement to a mechanical fix. But again, that's not been proven long-term with any great studies. So I wouldn't call it experimental. It has some potential to help, but I'm not sending patients with full-thickness rotator cuff tears for PRP in the hopes that they're going to avoid a surgery. Thanks for, sorry. So when you're dealing with bicep pathology, there have been a couple well-done studies that have randomized patients to either just snipping the bicep tendon to address that pain from the partial tearing and traction versus cutting and reattaching. A couple of the well-done studies have shown that at about a year out from surgery, most of the demographics and outcome measures in terms of pain, subjective questionnaires, range of motion, strength of their shoulder in general, separate from any rotator cuff pathology they may have had addressed, other than the cosmesis, is pretty similar. So every surgeon has kind of their own thoughts on who should get a tenotomy, who should get a tenodesis. Some surgeons do a ton of tenodesis. I use age and activity level as part of those. So the 75-year-old patient that I'm fixing a rotator cuff on, I likely, especially if they have a bigger arm, just cut their bicep tendon, especially if their cosmetic deformity is not going to be pronounced. Skinny 50-year-old laborer who I'm fixing his rotator cuff tear, I frequently do a tenodesis. There are some studies that show that there's some bicep cramping and symptoms more so in the tenotomy groups, but a lot of times that does wash out later into their recovery. So it is still somewhat a subjective decision, something that I discuss with patients when I have them in their office. A lot of patients are confused by why you would just cut something and leave it, and it just doesn't seem very commonsensical to patients. But I just try to explain the rationale of how the partial tears cause pain and what the relative risk and benefit of them are, because obviously the tenotomy procedure versus the way I do a tenodesis, there's some increased risk potentially and because of the anatomy of where we're working. So it's just a discussion that I have with patients if they want to know specifically about the pros and cons of both. But they're both effective in getting rid of pain from bicep tendon partial tears. Thanks very much.